Dear colleagues, today we present to you a case of a fetus who came to our attention at 12 weeks and 5 days. In these images, we observe a dilation of the bladder. We recognize the bladder, in fact, because we go from. We apply color Doppler and see that, in this case, there is a single umbilical artery encircling the bladder. So we can already define this as a case of megacystis with a single umbilical artery. We also see that, at the intestinal level, there are multiple small anechoic cysts, which we can clearly observe in these ultrasound images. Break time equals 0.5 s/. At first glance, it appears that the kidneys are present, although at this gestational age, it is quite difficult to observe them transabdominally. Detailed ultrasound imaging confirms the presence of a single umbilical artery in these images, where we observe a single artery coursing around and encircling the fetal bladder. Break time equals 0.5 s/. The right umbilical artery is clearly present while the left one is absent. Currently, the bladder measures exactly 15.3 millimeters. We also observe the clear presence of these cysts at the abdominal level. Break time equals 0.5 s/, which are not communicating with each other and are separated from the bladder, so they are not connected to it. And they are not connected to the small fetal kidneys. To better observe the kidneys, we need to utilize transvaginal ultrasound in order to more clearly and accurately define their presence. In fact, at this stage of pregnancy, it is very difficult to observe the kidneys, both because of their small size and because their echogenicity is very similar to that of the intestinal parenchyma. As a result, we can assume the presence of both kidneys, which do not appear to be dilated. Therefore, along with the megabladder, there does not also appear to be hydronephrosis. Therefore, we can define those cysts present at the intestinal level as intestinal cysts. Fetal megabladder is an anomaly characterized by a persistent increase in bladder size, diagnosed from the 10th week of pregnancy, when fetal urine production begins. In the first trimester, it is defined as a longitudinal bladder diameter greater than or equal to 7 millimeters. Generally, if the values are between 7 and 15 millimeters, spontaneous resolution can be observed in 90% of cases. Above 15 millimeters, the condition is always progressive. In the second and third trimesters, the diagnostic cutoff changes depending on the week. There are reference nomograms. It is an isolated finding in about 60% of cases. In 10% of cases, it associates with chromosomal abnormalities, including trisomy 21, 13, and 18. In 35% of cases, it associates with other syndromic structural anomalies, primarily anorectal anomalies and sequence. Vacteral, both of which are difficult to diagnose prenatally, megacystis syndrome, microcolon, Popper, Stolfi, and cloacal anomalies, as well as growth-related garlic syndrome. Continuing a detailed study of the developing fetus, break time equals 0.5 s/. We see that there is another cyst, this time positioned at the level of the umbilical cord. So we see this cyst measuring 12.3 millimeters. And to define it, it's precisely a cyst of the cord. We go to look for the vessel, which is right next to the cyst. So this is a simple cyst of the umbilical cord. It has no pathological significance, but it must be considered in the context of the other anomalies detected. The rest of the fetal anatomy that can be examined at this stage appeared normal, with a normal head. We can see, in fact, normal choroid plexuses, so a head appropriate for the gestational age, a normal presence of the nose, and a normal, thin nuchal translucency. So, typical normal brain anatomy is also further confirmed by the presence of standard normal posterior fossa spaces in the head and a normal intracranial translucency. We can also see that at the abdominal level, we are able to sample the duct. Venous. The fetus was also very active, so in some cases the Doppler is affected by fetal movement. We can also see that the cardiac anatomy, as far as it can be explored by ultrasound at this stage, appears normal, with regular 3 vessels and normal filling of the 4 heart chambers. So, overall, the cardiac anatomy was absolutely perfect for the gestational age. Megacystis microcolon intestinal hypoperistalsis syndrome is a rare congenital disease characterized by significant abdominal distension caused by extreme dilation of the urinary bladder, which is not obstructed, a microcolon, and decreased or absent intestinal peristalsis. In these cases, the bladder is enlarged and not obstructed, and it is the first symptom of this syndrome. It can, in fact, be identified during the prenatal period. This causes abdominal distension, which is an early and constant sign. The clinical picture is similar to that of neonatal intestinal obstructions, and patients may present with various abnormalities of the digestive tract organs, such as, for example, microcolon, intestinal malrotation, hypo or generalized intestinal aperistalsis, and short bowel. Along with megacystis, there may also be malformations of the urinary tract, with dysplastic kidneys, hydronephrosis, and ureteral dilation or hydroureter, which, however, was not present in this case. In some cases, cryptorchidism or congenital heart disease, umbilical hernia, or an omphalocele may also be present, which in our case were not observed. The prevalence of the disease is not known. It has been described in 230 patients, 71% of whom were female. So sex is very important. In this case, we had the impression that it was a double X, even though the very early stage did not allow us to be certain. The etiology of this condition is not known, but several hypotheses have been proposed, including genetic, neurogenic, myogenic, and hormonal hypotheses. As for genetics, it is an autosomal recessive transmission, and most likely the region involved could be a region of the chromosome 15, long arm 11.2. Therefore, it is always necessary to carry out genetic counseling to rule out the risk of recurrence in a subsequent pregnancy. The differential diagnosis, on the other hand, can be made with another disease of autosomal dominant inheritance called idiopathic chronic intestinal pseudoobstruction, which has much milder symptoms, and in which the white bladder is also present. This is also associated with prune belly syndrome, in which there is also the abnormal dilation of the bladder, kidneys, and ureters. Break time equals 0.5s/, and the characteristic of the disease is the distinctive weakness of the abdominal muscles, which gives the belly a wrinkled appearance similar to a prune. As for prenatal diagnosis, we've already seen that this abnormal dilation of the bladder can be detected, usually recognized in the 2nd trimester, even though in our case there was an early diagnosis. With the subsequent appearance of hydronephrosis, reduced intestinal motility, a thin colon, specifically this microcolon. With intestinal hypoperistalsis, and furthermore, in the 3rd trimester, polyhydramnios may also be clinically observed. The disease is highly lethal, despite the significant advances that have been made. Break time equals 0.5s/ specialized treatments, which are never curative, such as surgical interventions like gastrostomy and jejunostomy, are generally ineffective in most patients. Break time equals 0.5s/ in addition. Total parenteral nutrition has often been utilized and administered to improve overall survival. However, life expectancy is low, and the prognosis is unfavorable. Death is usually caused by sepsis, malnutrition, and multiple organ failure. The fetus is affected by multiple malformations. There is a megabladder currently measuring 15.3 millimeters in diameter, the presence of multiple cysts in the fetal intestine, a single umbilical artery with the right present and the left absent, and an isolated cyst in the umbilical cord. The most likely diagnostic hypothesis is that of megabladder microcolon intestinal hypoperistalsis syndrome, MIMIS. However, this diagnosis is only made after birth by studying the small intestine. It is important to note that in specific cases where a pregnancy is terminated, it is necessary to collect a small sample of fetal skin to be carefully preserved in a saline solution at room temperature for subsequent genetic testing. Genetic counseling and the study of the fetal karyotype with Rick are necessary to assess the possible presence of RA-sopathies. This specific clinical syndrome, in the event that the pregnancy is terminated, may frequently go unrecognized because megacystis, since it is not present with any visible alterations of the bladder walls, and not being due to any urethral obstructions, and with no presence of megareader, might not be detected during the anatomopathological examination performed post-mortem. The autopsy after the abortion appears to be entirely normal because once emptied, the bladder looks exactly like a regular bladder. And even the microcolon is difficult to recognize, except by anatomists. Expert pathologists, that is. Therefore, it is necessary to carry out genetic testing in order to rule out the presence of the disease, and to be able to determine the risk of recurrence in a subsequent pregnancy. Precisely because, as we have already said, in most cases the disease is autosomal recessive. Therefore, it may recur in subsequent pregnancies. Thank you all for your attention.